All right, so we have arrived at our last, but definitely not the least, lightning speaker of the morning, and that is Dr. Frederico Angriman from Sunnybrook.
Thanks so much. I'm Federico. I'm a critical care physician from Sunnybrook, and I'll be showing some of the highlights of our work that has focused on the impact of diabetes on sepsis-associated outcomes. As you heard, I'm biased in terms of my interest towards long-term outcomes after sepsis, and especially focusing on cardiovascular disease. When we think about the long-term outcomes after sepsis, or that sepsis survivors face with a specific focus on cardiovascular disease, we can think about different pathways, and those pathways likely include an interaction between sepsis and baseline comorbidities, a pathway that may be a direct pathway from sepsis directly to long-term outcomes on cardiovascular disease through changes in the inflammation, coagulation, you name it, or a pathway that includes the impact that sepsis has on acute organ failure, such as respiratory failure and kidney injury, then subsequently changing the incidence of long-term outcomes. So what our group has done in the last year and a half was essentially evaluate what the impact of diabetes is in patients who survive sepsis in terms of cardiovascular disease. And perhaps not surprisingly, we found that patients with pre-existing diabetes who survived sepsis were at an increased risk of cardiovascular disease compared to patients who survived sepsis without diabetes. This was perhaps expected. What we were surprised by was that there was not a higher risk of the competing risk of non-cardiovascular death or the risk of recurrent sepsis. We found significant effects for the composite of myocardial infarction, stroke, and cardiovascular death, but we also found increased risk in the standalone endpoints of myocardial infarction and stroke. What is most interesting to me, at least, is the second finding that diabetes intensifies the effect that sepsis may have on cardiovascular disease. So when we think about sepsis survivors, and if we compare those sepsis survivors to patients who survive a hospitalization not due to sepsis, we may agree that those patients who survive sepsis have a higher cardiovascular risk than those patients who survive a non-sepsis hospitalization. And what diabetes does is, apparently, it increases or intensifies that effect. So if we build a gradient of cardiovascular risk after someone survives the hospitalization, the lowest risk is among those patients who don't have diabetes and who didn't have sepsis during the hospital stay, and the highest risk is among those patients who had pre-existing diabetes and survived a sepsis episode. And this essentially means that there's effect modification if we believe there's an effect of sepsis on cardiovascular disease by pre-existing diabetes, and that essentially is reflected on this increased absolute risk among that subgroup. And the third highlight that I'll bring today is the impact of diabetes on short-term outcomes among patients with sepsis. And this comes from a very big population-based cohort study that's currently under review, which included close to 200 patients with pre-existing diabetes and sepsis, and close to 300,000 patients with sepsis and without pre-existing diabetes. And what we found is that pre-existing diabetes among patients who had sepsis was significantly associated with new acute kidney injury requiring dialysis, and not a very, at least clinically meaningful risk of invasive mechanical ventilation. This means respiratory failure requiring invasive mechanical ventilation. Also notably, patients with pre-existing diabetes and sepsis had roughly the same all-cause mortality risk at 30 and 90 days compared to patients without pre-existing diabetes and sepsis. So in essence, when we focus on sepsis, on patients with sepsis, those who had pre-existing diabetes potentially have more risk of acute kidney injury, but similar risk of respiratory failure requiring invasive mechanical ventilation, and a similar risk of all-cause death within the hospital stay and at 90 days. In terms of overall significance, I've come to believe that sepsis may be conceived as a major risk factor for cardiovascular disease, and the cardiovascular risk in sepsis survivors may be even higher among those patients who have prevalent diabetes, and this may change the way we think about them once they leave our hospital. And pre-existing diabetes is also associated with a higher risk of in-hospital sepsis-associated acute kidney injury. I believe that the role and mechanisms of pre-existing diabetes and short-term outcomes after sepsis is still to be defined, and we also have a lot of road ahead in terms of what we do with the risk stratification regarding cardiovascular disease after a patient survives a severe infection. And I'm going to stop there. Thank you so much. And this is our team. Thank you.
So I know that at the end you said that the cause of this increased cardiovascular risk for people with previous sepsis is currently unknown. But my question is, do you have any potential suggestion as to why? What are the risk factors?
Thank you. That's a very good question. I don't have a good answer for. I think today we have better. It's paradoxical, but we have a better sense of what the observational data is telling us in terms of huge population of patients who survive sepsis, and we have the sense that they face a higher than expected cardiovascular risk. However, I think we're still lacking on the mechanisms, and that may mean either two things in my mind. Either that's not a true association, it's just a reflection of baseline severity of comorbid conditions, and that's why I include that pathway. Or it just may mean that we need more basic models to fully understand the mechanisms. If you ask me, those likely include changes in inflammation, coagulation, complement pathways, changes in the endothelial function, but I don't have evidence to say that that's the case. So it's difficult for me to say, well, that's a true effect. It's a robust association, let's put it that way. Whether it may be completely blown away by severity of disease and unmeasured confounding, maybe so. Good, robust studies have still shown an association, so I think there's merit in fully understanding what those basic mechanisms are that we don't know. And if we do that, then we may start thinking about prevention strategies after a patient survives sepsis.
So Fedi, the ICES database has been rich for understanding this with its current limitations. One of the limitations and one of the things that we were asked at the beginning is what's this relationship to obesity? And does obesity add an extra confounder into this pathway? Michaela can tell you she's spent 4 years of her PhD trying to sort that out from a molecular biology and immunology perspective, and it's not easy, right? If we were going to design a prospective observational study, what would be looking at, what were the gaps that you couldn't get out of ICES that you'd like to see prospectively?
That's a great question, thank you. Obesity is one of them. Habits such as smoking is another big gap in ICS data sets, and then blood work and extensive blood work that, if you ask me, I would love to have a prospective cohort that may divide patients with sepsis into different phenotypes, either by the ones that have been described before, and then looking at the cardiovascular risk during long term. Some groups have done that simply in the past, not a long time ago. That's what I would love to have. We do have evidence of effect modification by diabetes and age. So young patients seem to suffer more that high risk of cardiovascular disease after sepsis, which may just come back to the point that they don't have classic cardiovascular risk factors, and that's why we see a higher relative risk. But obesity and habits are two big ones if we take away blood work.
There are two StatCan databases that may help you get at some of this, and that's the Canadian Community Health Survey and the Canadian Health Measures Survey, both of which have well, the CCHS has 65,000 adults
Yeah.
per year. Over the last 20 years, there's more than 500,000 people. A relatively small fraction of them have sepsis, but you can identify them by linking the CCHS to the discharge abstract database.
Yes.
Similarly with the Canadian Health Measures Study. So those are sources, you probably already thought of this, where you can get that information either in the first case by self-report or the second case, which is smaller database, by actual measurement, and you can get weight and height and things of that sort, and the A1Cs even.
Yes, yes, indeed, yeah. Thanks, Alan. Thanks so much.